We start with the people on the phone, please.
Hi, everyone. This is Fozzie Sabi, MathMG. I'm sorry I can't be there in person.
I'm sorry, who is it?
Fozzie Sabi.
Oh, yes. Thank you, Dr. Sabi.
You're welcome. Good morning.
Good morning. Okay, then. I think we'll start with Linda in your corner of the room, and we'll go around counterclockwise.
Linda Costa from the University of Maryland. Nicole Stallings, Maryland Hospital Association, sitting in for Beth Miller.
Elsa Haile, HSCRC.
Good morning. I'm Tom Valek. I'm a partner with Discern Health, consulting with the HSCRC staff.
And you heard from me already. This is Diane Feeney.
Allison Schuster, HSCRC.
Teresa Lee, the Maryland Healthcare Commission.
Madeline Shea, Delmarva Foundation.
Raquel Sampson, DHMH, sitting in for Karen Matsuoka.
Rosemary Murphy, DHMH with the Medicaid program.
Ed Baranik, Johns Hopkins Health System. Justin Dybel, Mercy Medical Center.
And I see perfect timing.
Good morning, Dr. Lynn, Care First.
Thank you very much. So we'll check from time to time to see if we have more people on the phone, and thank the handful of folks who also attended as audience members and participants in this process. Thank you for coming. Okay, so I think if we just walk through this agenda first, it will be the Tom Valek show for the first couple of agenda items, and he'll explore sort of framework, vision, concepts, measures, gaps in measurement, et cetera, for two areas of measurement. One is patient-centered healthcare measures, and then the second area is population-based measures. And I would encourage people after each agenda item to please ring in or chime in about your own perspectives on these areas. The next item on the agenda is the balanced scorecard, and this is more of a concept discussion as well. And what we want to get at here is sort of couple things: agreeing on the audience for this scorecard. We have something in mind, but we want to get some discussion about that, and then make sure the domains are all there. And then this is not going to be completed in this meeting. It will be something that will continue in the May 9th meeting. And then, of course, we'll have questions, any other questions, and then we'll adjourn. So with that, we can go ahead. And two things. Please use your microphone. And we know that folks that you have to push that button that says push and make sure it turns green, this little ring here. Otherwise, people have a hard time hearing. The other thing is, folks on the phone, please raise your hand. There are people monitoring the webinar, and we are recording this in two parts. So we'll make a 5-second break, probably around after the time that Tom finishes population-based measures, in order to get the logistics for the recording. And then the third item is that we need to make way for another meeting that's going to happen shortly after 11:30, probably 15 minutes. We all need to kind of be out of the room, 11:45. So just want to make that clear, and we'll commence. And Shuli, I think, is joining us shortly. She had something come up this morning.
There we go. So good morning again, everyone. I'm pleased to have the opportunity to talk with you about two very important and forward-looking areas of performance measurement this morning: patient-centered measures and population-based measures. These are, I think, particularly important to our work because if you look back at the agreement related to the waiver that we have with CMS, the sort of headline is that the all-payer system in Maryland will move toward patient-centered, population-based approach to care, to financing, and therefore also to measurement. So I think even though a lot of what I'm going to be presenting may feel future-oriented, I think the future is also now in terms of not only our opportunity, but really also our requirements. This will be the second and third in a series of presentations that I'm giving on what I consider to be sort of the more forward-thinking measurement areas. The one from the last session, some of you were able to be a part of, was about efficiency measurement, a particularly complex area of performance measurement. Population-based measurement is also somewhat complex. I think patient-centered measurement is a little bit more straightforward. And then in the next meeting, I'm also going to be presenting on ambulatory care measurement. And that, I think in many ways, is going to be an area that we're perhaps more familiar with, at least in the quality community. But we need to figure out how to link that with what we're doing on the hospital side in promoting more integrated care. Another thing that's important to think about as we move through this series of measurement topics is how they're all related. When I talked about efficiency measurement at the last meeting, we talked about how topics we had discussed previously for 2014, like readmissions or complications, the potentially preventable complications, actually have an efficiency component to them. And as we march through some of these other topics of measurement, we'll see that they not only connect with efficiency, but they also connect with one another in various ways that maybe will allow us to start to think about how we can get down to that right set of measures that are practical and feasible, and I'm going to talk about phasing strategies, but that also link together in ways that make sense from various perspectives, from the patient's perspective, from the hospital's perspective, from the policymaker's perspective. And that's what we're going to start to talk about as we move into the discussion regarding the dashboard, or as Diane calls it, the balanced scorecard. So how do we start to make sense of this for public consumption, for financial incentives, for improvement? Okay, so we're going to dig deeply into patient-centered measurement. And I've purposefully titled the presentation Measuring Person-Centered Care, because I think as we start talking more expansively about the next version of the waiver, or the extension of the waiver, we're really wanting to get outside the four walls of the hospital. We're wanting to get toward population health. We're going to want to move toward more integrated kinds of care as we talk about connecting to physician practice and post-acute long-term care. So not all those people are sick. In fact, as we would hope, the majority aren't. And so it isn't just about patients, although that may be our starting place in the phasing, because we've got to start with what will work for the hospitals out of the gate. But we want to move toward person-centered care in this regard to include people who aren't sick. So I'm going to talk about the framework here for measuring person-centered care. As with efficiency, we're going to start with definitions and principles. These are ones that I've pulled from various sources, and you may agree or disagree with them. And I'm hoping that, that you'll have comments about these definitions and principles. But we do need a starting place that we can at least generally agree to when we talk about these complicated areas of measurement. And then there are some methodological issues regarding person-centered care that go to not only meaningfulness, getting good measurement information, but also to the feasibility of collecting the information. And we've got to be thinking about feasibility as we think about how to phase an approach that will work for our program and for hospitals. And then I'm going to talk about the measure types, the major measure types for person-centered care. And I have Diane disseminated as part of this a measure scan, both for person-centered care and for population health as part of the materials, that really is very broad. I think a lot won't be immediately applicable to what we're doing, but it'll give us something to react to. And last, and perhaps would generate the most discussion, would be about a phasing approach, how we can actually begin to incorporate some measures of person-centered care into the work going forward that will tie ultimately potentially to the financing as well as delivery improvement. We had a lot of discussion about the phasing at the last meeting on the efficiency measures, so perhaps that will generate some questions and discussion. What is person-centered care? Well, I pulled a couple of snippets from NQF work that I was involved in before I left NQF 6 months ago that I think is fairly comprehensive and sets up some themes that I'll be revisiting throughout the presentation. An approach to the planning and delivery of care across settings and time centered around collaborative partnerships among individuals, their defined family, and providers of care. Across settings and time, I think, is really important. This is going to connect to population health as well, and how to engage not only patients, but also individuals who aren't sick and whoever they define as their families and caregivers. And then I think the second sub-bullet here is important when we start to think about measure types. These are the measure type categories to a large extent. It's about health and well-being in addition to health care, and must be consistent with and respectful to the individual's priorities, goals, needs, and values. So we're going to be talking, for example, about shared decision-making and how priorities, goals, needs, and values come into that particular measure type. So if we draw from that definition, there are some key principles that go along with it. One of the things that you often hear from patient advocates and consumer groups is nothing about me without me. That's kind of something I keep in mind when I'm thinking about person-centered care. And so the measures have to be meaningful to consumers, and if they're built with consumers, that's one way to ensure nothing about me without me. And so a lot of these measures, I think, are developed in that vein, focused on the entire care experience rather than a single setting or program. I don't know how much more I need to drive this point home, but it isn't just about what's going on within the hospital's four walls, and so we need to think broadly, at least in the phasing. Measured from the person's perspective and experience, generally patient-reported, which raises methodological issues, but is a really important aspect of measurement of person-centered care. So some of those methodologic issues we should just talk about right up front because we need to keep feasibility in mind. So if you're going to collect patient-reported or person-reported information, you need an individual who is able to complete a survey, for example. And that's not always the case. That might not be the case in children, might not be the case in elderly folks, maybe with dementia, might not be the case in somebody who's just undergone a traumatic event. So sometimes it's important to think about proxy completion, and that enters into the validity and reliability of patient-reported information. The way that the tool is actually administered. Is it a survey? Is it done in a physician's office? Is it done in a hospital bed? These things affect the ability to collect information and the validity and reliability. Sometimes a survey tool asks a question, and the answer might be informative, but it isn't actually a performance measure because it doesn't tell you about a change in performance over time. Is something getting better or worse? It may just be a piece of information, useful in and of itself, but not really a measure. So that's a methodologic issue to turn a survey question, for example, into an actual measure. how to aggregate this information at the level of an organization. Attribution can come into play here. Whether the survey tool or the way of collecting the information is about something global, like your general experience, or something condition-specific that relates to your heart failure treatment and whether or not the care transition for heart failure patients was effective. So global versus condition-specific. And then we always have the issue in measurement of risk adjustment and stratification. If we're treating these measures as outcomes, we'll want to make sure that they're appropriately adjusted to reflect the specifics of the patient population. So as with efficiency measurement, there are a whole series of methodological issues related to measuring patient-centered care as well. Just got to get my clicker to work here. Okay. So now these are the 5 categories. There may be others. These may not be completely exhaustive. They certainly aren't mutually exclusive. Again, as with efficiency and population health, we're going to be talking about next, you can lump and split in various ways as you're categorizing measures. But these are ones that when I was at NQF, we often used to describe broadly the various measure types for person-centered care. So experience of care. We're going to be talking about examples of each of these: health-related quality of life, burden of illness, typically about symptoms, shared decision-making, which is on the ascendancy, and a sort of nascent area that is also gaining momentum that we don't have a lot of good examples for at this point in time, but I think is going to be more important in the future, which is patient navigation and self-management. In some ways, well, I was going to say these are actually in some kind of order about like maybe ones we have most experience with over time and least. That's not really the case, but we have more experience with experience of care through CAPS, which I'm going to be talking about as an example. But we have some good experience with pain symptom measurement and management under burden of illness. I think less with shared decision making, less with health-related quality of life, and even less with patient management, patient navigation and self-management. So let's talk about some examples. The first is a category that I actually didn't have on the previous slide, which is just general assessment of person-centered care. And there are a few measures like that in this scan. I think a good example of that is a composite measure that is in respect to children who receive family-centered care. And as a former pediatrician and thinking about the care we provided at Children's Mercy Hospital, this would have been a great composite to have at that time. Partnering with the family, listening to the patient and the parent, spending time as needed, sensitive to family values and customs, having needed information in order to understand what's happening with care and follow through, ability to access interpreter, which has become a requirement. So a good example of a comprehensive measure. Now, the next example, HCAHPS, is one that we're very familiar with, and I don't have to spend a lot of time on it. But every time I look back at it, you know, I'm just impressed with how much good information there is in HCAHPS. And in many respects, as a starting place that's already in place, it really has moved us forward. It has aspects of communication, of coordination, of responsiveness of hospital staff to the person and family's needs. And a lot of people still characterize it as patient satisfaction. It has that element too, particularly around cleanliness and quiet. It goes way beyond that, as you all are well aware. So there's also, to dig more deeply on the communications aspects that are covered in HCAHPS, there's the CCAT. It's actually developed by the American Medical Association. Some of you may be using this in your organizations. But it allows a deeper dive on communications, health literacy, cultural aspects, and so on, all very important ultimately to engaging patients and getting to that elusive area of self-management. The next one is, again, focused on children's care. It's sort of like the analog to HCAPS for children. It's developed by the Boston Children's Hospital, and it has even other domains beyond what HCAPS contains, particularly around medication management. 62 questions, though. And again, we need to think about feasibility and burden, not just to the hospitals, but also to patients and families, particularly families with sick kids. Say, here, fill out this 62 question survey. Now to the area of health-related quality of life. I talked about the intersection among these different broad categories of measures. Some of the things that you would expect, given the title of the category, intersect not just with person-centered care, but also with health, so you get to population health, but also with health care. For example, functional status change, which is another really good outcomes measure, is included here because it's patient-reported. There are a series of NQF-endorsed measures on orthopedic functional status, from hips to knees to ankles to shoulders, that are great measures not only of what the patient is reporting about their function and improvement in their function over time, but also of the provider's perspective on care and their effectiveness in care. And from other perspectives, like employers, for example, depending on the age of the population, getting people back to work. So these measures cover multiple different categories. You see two other examples here. An assessment, valid and reliable assessment of physical and mental functioning, and a screening for depression follow-up. Some of these are more or less immediately applicable in the hospital setting, remembering that we're thinking more broadly than that, but that is our starting place. Burden of illness, though, I think is pretty applicable to the hospital setting, particularly the pain assessment aspect. As we were putting together this measures scan, we thought, well, what else might we put into burden of illness? And we kept coming back to falls. That may not seem an obvious fit to everyone, but there's something about frailty and burden of illness that makes falls, I think, a pretty good proxy in this category. For shared decision making, now this is an area that's getting a lot more attention because it's hard for us to jump right to patient activation and self-management without involving them in the steps that would lead up to being able to be someone who can be activated and manage your care. So being involved in the care planning, the establishment of goals, making sure that those are concordant with preferences, very important. And again, some of these relate back to the efficiency discussion. We talked about back pain imaging, for example, as an appropriateness measure when we talked about efficiency, and involving patients in the cost-benefit and other trade-offs around back pain, not only imaging but also surgery, be a really good example, I think, of shared decision-making. There's good shared decision-making tools around breast cancer treatment, for example, and a woman's values and preferences around the options of surgery and radiation and chemotherapy and so on. There are some others that you see here. We also talked about end-of-life care during the efficiency discussion, and advanced care planning is important to make sure that we're respecting preferences, and also a requirement. Last but not least, in fact maybe most difficult, patient activation, which requires the ability to self-manage, as I've said. So this idea of health literacy and understanding the care, but also we put caregiver support in this category. Another piece that's getting a lot of attention as the population ages, and probably a lot of us in this room are taking on roles of caregivers in various ways, shapes, and form. We need to think about caregiver support. There are a couple of measurement examples here, but we don't have a lot of good examples in this category. Probably the best one is the adults taking insulin with evidence of self-management. So the last slide in this this section is a phasing slide regarding person-centered care. We have a good head start, as I had said earlier, with HCAHPS and with what I know organizations are doing around managing pain and paying attention to patients' burden of illness and symptom management. There are a number of activities that I've seen, at least at the national level with HA and the state level, through the various state hospital associations, taking around cultural competency. There are some requirements, as we said, around translation, et cetera, but it goes beyond that to really understanding how to connect with people where they are from a cultural perspective. And some early work in shared decision-making. It's one I think we could move into fairly quickly and would be of great benefit to patients, but also impacts other aspects of care, like think back to that back pain measure and to the imaging and surgical implications of that for efficiency. So then what might next steps be? Well, we ultimately want to get to patient self-management. But another next step I think that's on the horizon is looking to functional status as a kind of measurement that is not only patient-reported, so touches on patient-centered care, but really gets to what's important in terms of improvement in function and ability to live life for patients, and also is the ultimate goal for the providers, the physicians, the hospitals, to get people to where they want to be. It has an aspect of preference in it. Not everybody is going to be interested in or even able to achieve full recovery or the kind of function that they might have been able to achieve at some point in their life. But it's about setting goals and achieving those in terms of functional status. So those would be great outcomes measures to get to. So I hope this has prompted some thinking and some questions for discussion.
I'm Tracy Laval from MHA. I thought the presentation was well put together and gave me a good understanding of things that I don't see very often. My question is kind of taking a step back, and I may have missed this because I came in a little bit late, but I'm not clear of the context on why we're looking at these measures when we've got the list of metrics that we need to monitor. And last meeting we were talking about efficiency, and I think a report is due on efficiency. So I'm just wondering how this fits in that context.
That's a good question. Let me start, and then if anyone would like to add, please do. I think one of the charges of this work group is to, by the end of this phase of the process, have developed a framework vision document that tells us where we're going to go in the medium term and the longer term related to performance measurement, such that we have a very well-balanced portfolio of measures that measures the areas that are important, that we need to be mindful of, that have to be on the horizon in terms of adding them going forward. So this also will be feeding very specifically into the balanced scorecard discussion that we're going to have after Tom talks about population-based measurement. so that'll be a more tangible, how do we meet these metrics in the contract. We wanted to get this a little more theoretical and conceptual so that we could sort of frame it and then get specific underneath. So that's the context. Is that helpful? Can you turn that on, please?
Sorry. The efficiency report for the April deliverable. So that's kind of end of April deliverable. We are working on putting Tom's presentation into a report and incorporating the comments that we got, and we're going to send them to you next week for your review. And depending on the timing, if we need to discuss in a more extensive, I thought the discussion in the last meeting went really well, and I thought that we were ready to write the report and get some comments by email, and then if we are ready, we can submit it to the commission. And on the earlier question, I just wanted to say, we're trying to frame it, but at the same time, I would encourage you to look at the market scan and then think about if there are any measures that we should start thinking in terms of putting it in pipeline. Staff is going to review those measures as well, and we may come up with some kind of a priority list, or I think Tom has a good phasing in terms of which measures we think could be done on a more immediate term if we identify this vision of the patient-centered, if we define it collectively.
Right. Some examples, like you want to say? Go ahead.
Yeah, this may be too detailed of a question. So if it is, that's fine. When we talk about adding measures into the pipeline, are we talking about measures that will become part of QBR, or are we just saying measures to monitor, or it may be that we haven't decided that yet? And
I think we haven't decided. Pipeline measures are ultimately always candidates for payment, but we wouldn't rush to payment without monitoring, I think, first.
I mean, some measures might be ready, some measures may not be. So I think the critical part is we don't have a good sense at this point. The measures that are out there, we don't know their strengths and weaknesses and whether they are feasible for our state.
To the point often that before we start paying for things, let's get to know the measures, start looking at them, get used to them, look at the data, that sort of stuff.
So I think the other part is what gets measured, gets paid attention to. So the parts that I liked about this was all the shared decision-making parts, because those are things that lend themselves to reductions in unnecessary services. So it sends a message if those things are measured.
Thank you. There's two other things I wanted to bring up. The end-of-life discussion, I think Dr. Nguyen was talking about this, or had written a note about it in the efficiency context. But I do think it's squarely in the domain of patient-centeredness or person-centeredness, in that, and in fact, we don't do that very well in our state. So I think things like, do patients really have their living wills in place, or families' preferences and ideas and wants understood and documented during end of life? Do people take the time, providers, to understand what those things are? I would love to see a measurement focused on that in the earlier midterm, as opposed to waiting a long time, since it seems to be an area where the state needs to improve. The other thing is, I'm going to put Anne Arundel Medical Center on the spot. They have very robust patient involvement in decision-making, in governance, and in policy-making. And that's not an area where this presentation focused, but I do think if you have patients involved at that level, then some measures organically emerge from those that involvement. And for instance, their discharge planning process was greatly improved, I think, from the things that I've heard, because of patient involvement in restructuring and redesigning that process. What did the patient care about? when they were being discharged, and what things, there's a form, et cetera, that came out of that. And so that could maybe be considered somewhat of a structural measure. How does a hospital or system involve patients at the earlier stages it goes to disclosure and transparency and a whole lot of other things, and we'd be surprised what people who receive care are capable of in those areas. So I wanted to just raise that area as well. I think what we've done, Dr. Buzz, had we can probably break to audience questions now. So if you'd like to, and after, okay, go ahead, Barbara, after you joined us. Welcome, Barbara.
Thank you. After the table, I was listening on my way.
Okay, great.
I have a question, comment, suggestion. First of all, back to Tracy's comments and questions. When we're looking at the time span for this pipeline, I assume that's 15, not 14. I assume 14 is set for policy, correct?
Even, I mean, if you're just talking about QBR, 15 is also set.
That's what I thought.
Yeah.
Because
and
that's why the pipeline
16 is set too.
Well, yeah.
If you count the, the rate year, 16
right.
is set.
So right, that's why the question about the pipeline, number one. But number two, because maybe some of the items in current year, meaning fiscal 15, practice is 14, I'm not sure we've totally closed that chapter so that the state really understands the hospitals really the importance. Say a PCI 90, that's a much more complicated measure. It's 10%. The mortalities, we've put CLABSI back in. And here's the suggestion. HCAHPS has been a struggle for Maryland. We're still struggling, but I see a lot of progress that we talk about in the MHA Quality Council. Would we not want to take some of what we're hearing from Tom's presentation, and if we're going to look at new measures, look at where some of our issues of fallout are in the HCAHPS results, for instance, because this is such a broad field, and I certainly agree with the importance. But if we're to really focus, because it is getting to be such a broad pot of things that we're looking at in Maryland, to really focus where we've had issues, struggles, and progress might be a way to go. But I think the issue of pipeline is a little bit confusing simply because you're right. 16 is already set, and if we're talking about policy versus goals versus efficiency, I think it would really just help to see how that fits.
Just a point of clarification. So when we're talking about performance year versus payment year for, I just want to make sure I'm clear. So we added measures in 14 performance, and I know what we're going to add to 15. I don't know that we've added measures for 16.
I was going by the rate year.
Right.
So for
okay,
performance
I just wanted to
year,
make sure we were all saying the same
for
thing.
performance year, calendar year 14 is set, and end of summer.
Added for 15.
Right, end of summer, we are going to start talking about what will be the measures for calendar year 15,
which will be 17.
Right, and there are some NHSN measures that we know I think makes sense to be added at that point, but they will be open for discussion.
Right. So this discussion could feed into some of those in terms of concrete what measures we would like to focus on. And I agree with you. If you think about it, we are focusing on readmissions. We are focusing on PPCs. What should be our focus on the patient-centeredness, population health domain? There are so many measures, and I think it's a great suggestion to see, okay, let's look at where we are behind and then find some things that we can shortly impact. I think
right. Again, just for continuity, for some connectedness, and then also because the field is so extremely broad. And I think before people jump into population health, we really ought to have a plan.
I like all of these measures. I like the whole focus. I think part of the issue is how do we craft something so that hospitals are the appropriate place where there should be accountability for this. And I think the idea, and you mentioned it, the structural measures would be a good way to kind of get at some of this once you get closer to being ready to talk about it, to see if, in fact, for example, hospitals have a program in place that will address shared decision-making, and you agree that this program is a candidate for it, and then there's some outcomes associated with that specific program, and if they can achieve that, then there's something there. But I think these are really good to move forward with, but I think they are really broad, and the devil is in the detail and narrowing it down to what hospitals can do. So,
right, and so, Teresa, I will thank you in advance for the work of MHCC and helping us to figure that issue out, and because that's how sort of we've been working all along throughout this process, is the measures that are first adopted and reported, and then get into the payment scheme. So, and we'll work collaboratively, I'm sure. So are there others? Oh, come on up, and Ed, I'm sorry, Justin.
You want me to go now?
Yeah, go ahead.
I think I just wanted to piggyback off that comment because I think it's very appropriate, and I think that's what you were trying to get at with some of the phasing in your document. Like, there's things that we can work on now, and there's things that are kind of longer term, and obviously this list of 60 measures was very broad. Some of them not terribly applicable to hospitals, but at the same time, knowing where the rate system's going, knowing what the waiver said were the goals in the 5 years, and ultimately if we are to reapply for the next 5-year window, I think some of the goals were to be kind of broader than just hospitals. So we may want to think about capturing data that's broader than just hospital, at least to start setting a baseline for that future period. So maybe what we have to do is kind of carve that off into a separate conversation so that we don't kind of confuse the issue of what we're trying to capture with this hospital system that we're in right now. But maybe we do need to start thinking, because 5 years will come on pretty quickly, and then we won't have any data, we won't have a baseline, we'll be in the same spot. So I do applaud the efforts, and I think maybe we could capture some data to create that baseline. And I did want to make one other point on what you just mentioned about Anne Arundel and the good work that they're doing. I think it would be good if we could consider some type of forum for that best practices sharing, because it seems like it comes out in dribs and drabs and comments at certain meetings. But if we could have some type of forum that was facilitated with these things to say, hey, this is what one facility did that was successful, maybe we could implement that in others, or maybe others would be interested in doing the same thing.
And we'll quote the finance guy named Justin in our report. I think MHA has really tried to be the convener of the forum, the fora of best practices in various efforts, including the HCAPS work, as well as care transition work. But I think it hasn't reached all the audiences and all the people and everyone. So we will continue, I think, to strive to do that.
And one thing we are doing at our annual meeting this year, we're for the first time we're breaking out and having a breakout session on patient and family-centered care. So that'll be led by someone from Anne Arundel and someone from MedStar, as well as a couple of other breakout sessions where we think there's some really great innovation going on in the field. But you're right, we try, I think we communicate perhaps a bit stronger to our quality folks because they're very used to a collaborative approach, and we need to really try to spread that to multidisciplinary groups.
Yeah, and the other place that might be of some assistance, I think, is that the Commission's working towards a global budget metric model thing that the hospitals will be reporting in on a monthly basis, and I don't know if some of that might come out in that reporting, and we have to figure out a way to share that back. Whether the MHA is ultimately the convener, that would be fine, but we have to figure out good ways of sharing the data across entities.
Dr. Best? Thank you for being patient.
No problem. Thank you very much. I'm Zahid Butt with Metasolve. And so, Tom, that was a great organization of a difficult area to get specificity in. But the current measures that are related to discharge planning, there are several in existence. that have components of patient education and self-care. Would you, even though they are provider measures and not per se patient reporting measures, would they be candidates for that category for navigation and the self-care?
Yeah, I would probably typically think of them as provider-oriented care coordination measures, which is another category that we might want to touch on, as opposed to, as you pointed out, patient-reported measures of their experience and understanding and activation and self-management. But the categorization and the lumping and splitting isn't really what's important here. What's really important is the kind of discussion we were just having about the role of the hospital now, the role of the hospital in the future, how that fits in terms of moving toward patient-centeredness. And I think that those care transitions measures that you just mentioned are right on target for that. So even though they don't appear in this particular classification.
So this would be more sort of patient-reported measures, essentially.
That was one of the themes that I had wanted to hit on in this categorization of patient-centered measures. Thank you.
Speaking of NQF, so we know that I think about 2 weeks ago they were accepting comments for a socio-demographic adjustment, but an expert panel recommendations that for the first time were very strongly endorsing looking at some sort of adjustment for outcome measures. And as you were just talking, it made me think that health literacy, patient activation, those are things that were in that list of variables in that report that could be considered for adjustments down the line. And so to Justin's good point, perhaps if we could move towards starting to collect those things, because it could also perhaps be used to inform some sort of a future adjustment that we might want to do when setting targets, for example.
Right. Yeah, that's a really great point, very future-oriented, because if we're ever going to get to the kind of risk adjustment and or stratification that you guys want to improve payment, we were talking about when we talked about readmissions much earlier on, even complications, we've got to have those data elements. And if we have them for that purpose, we could also use them for measuring is the care getting better for people who have those kinds of characteristics. So I think that's an excellent way to go. By the way, I don't think we have the overall schedule of our meetings playing out over time in our packet today, but we are going to revisit that topic of SCS and other kinds of risk adjustment based on the NQF's recent report. I don't think it's May 9th. I think it's the meeting after that. And look at some other things that NQF is doing in relation to things we've discussed throughout our series of meetings.
I want to second that about health literacy. I think it might be easier to get at than cultural competency. There's very clear guidelines, toolkits. You know, even just looking at written health literacy, plain English language, it doesn't exist in a lot of places, and even starting with hospital systems, but throughout the entire healthcare system. So I'm going to put in another plug for that, not just for risk adjustment, but for an outcome measure.
So let me try to, I'm writing down notes to try to get, if you remember the QBR work, we were trying to get a measure stick to vet some of the measures. So what I heard you guys talk about, you know, availability and timeliness, hospital accountability could be another, you know, evaluation criteria. We can look at it. Broader focus, it's kind of going hand in hand. Accountability, yes, but also Justin's points about the broader focus. Problem areas, Barbara's point, importance for risk adjustment, outcome-oriented, and patient-reported. Are there other things that you think we can think about when we are looking at all these measures? And if you are trying to prioritize, what are other things that you think will be important if you are trying to create a patient-centered measurement list? I have it in my list. I may not have read it. Any other, did I miss anything?
I would just say, to the extent that they are aligned, so across other things, so if you're already reporting it for meaningful use, for example, or if it's NQF, I mean, just there's so many measures out there. So to the extent that we can try to align across various programs, I think that would be ideal.
You know, I'm a spreadsheet person. I'm going to put them all in. And
do we have any sensitivity towards disabilities in this when we're looking at person-centeredness? I would just say something to think about. All kinds of disabilities.
Yeah, there are a couple of in the examples, as Karen's pointing out. Sorry.
All right, then, great. So I think we'll continue on to the next presentation and discussion item, population-based measures and measurement.
So thank you for that discussion that keyed off of person-centered care, but I think it was very relevant as we move into the topic of measuring population health, because if we thought person-centered care measurement was moving us beyond the four walls of the hospital, that's exactly what this topic is really meant to be about. And so, again, I think all of the issues around accountability and phasing are going to be very relevant to our discussion regarding this topic as well. So again, a framework that will include definitions and principles. I pulled in a piece from a relatively recent IOM report on selecting measures for use in measuring population health, which I think will be useful because one of the things that we're thinking about here is measure selection. The measure types, again, that relate to the categories of measures in the scan that was distributed to you by Diane. And in fact, this scan of measures is even bigger, which doesn't mean that it's any more applicable to an initial phase for hospitals. But again, the idea for these initial overview presentations is just to give you a broad view of the landscape and then to have these measure scans as a resource as we talk about what we would like to actually proceed forward with. And similarly, a phasing slide to just get the discussion going. So I pulled from a very broad definition to get us started because I think that's important when talking about population health framing. And this is from the World Health Organization. And it is very broad. Complete physical, mental, and social well-being. I don't know how we could be more broad than that. But I think the important takeaway is that population health isn't just about the absence of disease or infirmity. So it's not just about better care, even though better care is a part of it. It's also about other aspects of life that we want to pay attention to, that we describe as health and not health care. So in a recent NQF commissioned paper that in some ways I think is becoming kind of the go-to article for this particular topic, you see here that there's a definition not of necessarily of population health per se, but of what we're trying to achieve through thinking about population health. Improving overall health status and health outcomes, not just through the clinical care system, but connecting and including government public health and even more broadly, other stakeholders in the community. So the clinical care system has an important role. Hospitals, as you'll see in a Venn diagram slide that I've done. But also, how does that connect with public health as we've traditionally thought of it, provided by the government, and also to many other community organizations, government, NGOs, non-government, non-profits, other kinds of for-profit organizations in the community. And then what population health might be influenced by is another perspective to get at how we're defining it. So it can be physical factors, biological, socio and economic factors in the environment, personal health behavior, so decisions that individuals are making that will affect their health, and then access is an important part of population health, and effectiveness of services, which takes us back to other things that we've talked about before, like readmissions and complications in terms of the effectiveness of services. So I wanted to pull in a reference to the National Quality Strategy at this point. Not that the National Quality Strategy isn't important as we're thinking about other aspects of measurement, like efficiency, like patient-centered care, but the National Quality Strategy really helps to remind us that there are three interrelated aims that we have that include not only better care, where we have traditionally focused in healthcare quality over time, but also healthy people in healthy communities. And it's about the interdependence among those goals and aims, and paying attention to them more broadly than just thinking about what's happening in the healthcare system. And of course, affordability is another aspect of that. And then the priorities under the aims get to various aspects of population health and other measure types that we've talked about. So for example, health and well-being or prevention, very important aspects of population health. So this was the Venn diagram I was referring to. I wanted to represent more broadly than just in the wording narrative how these three aspects of care delivery, government-sponsored public health, and community stakeholders really work together to support population health. And I think as we think about the hospital's role initially in our phasing of providing inpatient, outpatient, emergency, and other services in the community, how that connects with the government-sponsored public health system, how that connects with what's happening from others who are involved in health in the community. And this shows some of those intersections, which may be places where we might want to explore for measurement. So for hospitals, again, thinking about how we're conceptualizing this, it may be the entire geographic area or the catchment area for the hospital and the patients it serves. It may be from a provider's perspective, thinking of the hospital as a part of the medical neighborhood. How does the hospital fit with the ambulatory care services, the post-acute long-term care services, the home care, the emergency medical system, the public health in the community, all part of that medical neighborhood that the hospital's patients access. It may be based on thinking about the demographics of the populations that the hospital serves. So if there's a total population that the hospital might have an aspect of responsibility for population health, there are also subpopulations that might be even more important for us to focus on in order to get to some of the more vulnerable populations. Disabilities was mentioned earlier. It may be frail elders or children or the folks with low income. And there are measures for population health that are relevant to inpatient, outpatient, and community services. And hospitals, of course, have a deep and abiding interest based on their mission in promoting health and not just health care. And I don't need to spend a lot of time on this slide, but I wanted to point out that this isn't so foreign. Even though we are talking beyond the walls of the hospital when we talk about being accountable for population health, but this is what hospitals ultimately are all about. So the motivation of those who serve in hospitals, for example, in promoting health. Issues related to things we've talked about before, like readmissions and complications, have to do with how well or sick people are in the community who need to come back for services, or when they're discharged, what supports are they going to be having. So that's of interest to hospitals, particularly as they're being held accountable, for example, for readmissions and complications. Increased focus of policy efforts, I think that's related to the points about the national quality strategy. The fact that our data systems are becoming more sophisticated so that we can track patients not just when they're in the hospital from the hospital's perspective, but before and after as well. And then there's been a lot of attention, particularly from the Senate Finance Committee, about hospitals' nonprofit status, and whereas the healthcare services generate revenue, the community health, the population health aspects really go right to the nonprofit aspect of the mission. So this was the IOM logic model that I referred to previously. And it's not complicated. I think it makes intuitive sense, but it's good for us to think about where population health measures might fit in to the other measure selection activities we've been talking about, this pipeline we were discussing. So thinking about the interventions we want to have to make a difference and the resources we have in order to fund those, how those can impact health through affecting healthy conditions like behaviors that individuals take, connecting to the public health system. We talked about adjustment for things that are characteristics of the populations, like their socioeconomic, educational factors, and then the broader built environment and natural environment that impact population health, which, of course, then our ultimate goal in the logic model is better health outcomes, long, healthy lives for all. We can think about a simple example of influenza vaccination. If our goal is to decrease the morbidity and mortality through vaccination, we need to have an initiative to get vaccination levels up. It can't just be the hospital. It has to be other community organizations and other providers to work together to get the measured level of the influenza vaccination rate up. So it requires a joint accountability. So measurement is going to entail a shared accountability. But then we can look forward to the outcome of that kind of shared activity, which presumably in this case would be the increased number of vaccinated individuals and reduced risk of preventable disease. So getting to the measure types, the 6 that I keyed off of here, and there may be others that you can think of, and certainly as for the other presentations, these measure types are not mutually exclusive. But we have the broadest health outcomes that are tracked over time. These would typically be tracked, for example, in the ARC Quality and Disparities reports, or maybe Healthy People 2020. High-level indicators, that there's very diffuse accountability around these, so that may not be our best starting place. Measures of access, availability and use of services, measures that are very much related to decisions that people make in their daily lives, healthy behaviors. We're going to have some examples of those. Those are places to reinforce healthy behaviors. And to counsel and hopefully get success with influencing healthy behaviors. It's a tough area. Prevention, these are things that typically are part of primary care and other services in the community, but hospitals can play a role as well. And then the social and physical environment, where we've talked about health literacy as a part of the social environment and disparities, but how do we also impact the physical environment? So these broad measures of health outcomes that are typically part of national tracking, mortality, longevity, infant mortality and preterm birth, accident rates, for example, suicides. I think remembering that it's not just about physical health, but also about mental population health, and suicide rate is an important ultimate outcome that we want to keep an eye on. The one thing that does cross over, well, there are a couple things I think that cross over into the hospital setting. Mortality, obviously, in a much more narrowly circumscribed way. There are measures of mortality related to hospital services, and there can be various windows around that that can be followed. The idea of preterm birth, there's been a lot of focus on early elective delivery, and so that's a place I know where hospitals have made a lot of difference recently in the positive direction. In terms of access, we often think of access as primarily about insurance coverage, and I think it primarily is. But it can also be about access to needed services. I think we can think about emergency services, for example, here. But I thought a lot about these examples of hospital admissions measures, like, for example, ambulatory sensitive kinds of measures of hospital admissions, and whether or not those are really access measures, or whether they're overuse measures, or whether they're effectiveness measures about not having effective preventive care and primary care. So I'm not exactly sure where to categorize them, but I think there is something about watching admission rates that tells us about access to needed services, whether it's primarily primary care services or maybe whether it's hospital services in some instances. So you see some examples listed here for measures of access that go beyond just insurance coverage. Healthy behaviors. This could be about harmful substances like tobacco or unhealthy alcohol use. We often think of diet and exercise as the focus of healthy behaviors, and certainly the tracking of BMI. This is another area where I think partially through measurement at least we've had an impact. Childhood obesity has decreased, and we've certainly brought attention to the obesity epidemic and the relationship to diabetes and other diseases. And we've also had a lot of focus on tobacco intervention and cessation. In terms of preventive services, these could be about specific diseases and conditions, lots of cancer screening, women's health issues. Also immunizations play into prevention, and child development is also important to recognize. And again, we don't want to forget mental health in addition to physical health. So adult depressive disorder, suicide risk assessment, important there. So moving into social and physical environment, and these are places where the healthcare system hasn't typically been as involved and or accountable, but we're now seeing the important interactions between the healthcare environment and the social and physical environment. So we were just talking in our previous discussion about the importance of health literacy in patient activation and self-management and the relationship to cultural competency as well. Social environment, I think, is relevant to where we are with thinking about hospitals' role in population health, but maybe not our starting place. Physical environment, also, I think, harder for the healthcare system to directly impact. But I would think hospital leadership, hospital boards would be really interested in thinking about the health aspects of what's happening in their environment, like healthy food options, walkability of neighborhoods, air quality, so on. A specific NQF endorsed measure has to do with secondhand smoke and children's exposure. But in terms of the phasing, starting with healthy behaviors and preventive service for hospital patients. These are teachable moments, whether it's inpatient hospitalization or outpatient services, to say, you know, we've measured your BMI, and you need to be paying attention to these problems that could result from obesity, perhaps a referral. Preventive services, immunizations, for example, have typically been a part of when you think about discharge, if it's appropriate, if the patient hasn't been immunized, to get an immunization while in the healthcare setting. Also then, the assessment of community needs. So if hospitals are going to be engaged in population health management, focusing on the things that are most important to the population that hospital is serving, I think is a logical place to start. And of course, the community health needs assessments that are now required under the Internal Revenue Service Code as part of nonprofit status gives us a starting place there. And then the next step is collaboration with those who could also make a difference in some of these areas that we're talking about measuring. Because I don't think there are many in this particular list, and it's a long list of 84 measures, where you would point to them and say, yeah, that's just the role of the hospital. I think that when we think about population health measurement, we've got to think about the role of the hospital in working with the others in the community, that intersecting Venn diagram with public health, government-sponsored public health, other aspects of public health, with community services as well in order to meet the population health needs. So I will stop there and welcome discussion.
Can I ask? I think this is probably the most challenging measurement set for us to think about and try to move the needle. But at the same time, we already have the community benefits report and some work hospitals are already doing in this area. And I'm glad Raquel is here. I wondered if you can talk about your SHIP work and how it's connected with the community benefits reports, and what are the things that you think we can move forward, because now we have global budgets, most of our hospitals. What is your community, from the hospital perspective? What do you consider as your community? And then are there things we need to do with the community health assessment and the benefits report that we can start focusing? I'm probably the least qualified person to talk about the community health benefits reports. I have no idea what's in them, but I wondered if we can start from there and then kind of link with what those measure sets that Tom brought up.
I think we're very fortunate to have Nicole sitting in today, and I'm the DHMH Director of the Office of Population Health Improvement, and Maddie was formerly the director. So she really stood up the state health improvement process, where there are, at this point, 41 population health measures that we look at statewide, as well as break them down by county. So I think the very interesting part of that is that there has been a lot of work done, I think, to the credit of MHA, DHMH, and HSCRC around looking at improving the community health needs assessment piece, as well as the community benefit work, but I think we have a long way to go. So I think I'll let Maddie talk a little bit about the current work, because she's still serving on as the representative for the community benefit, but we have a lot to say around population health and the type of measures and the data sources. So what we're passing around now are the 41 measures that we currently have on a website that all of the counties utilize to look at their county, compare each other to one another, and compare themselves to the state.
And just before you go on, if you remember this list we distributed in the last meeting, the monitoring list that we have in the contract, the population health measures were kind of taken from this list. So it's a subset of the list that when we applied, we thought that would be the priority, and we thought that would be highly linked with the existing proposed model.
So I'd also like to say that all of the hospitals now in Maryland use these measures as part of their assessment process in their community health needs assessments. So I've evaluated these reports. This is the third year that I've done it, and I've seen tremendous progress in understanding community health needs based on multiple sources for most hospitals, including population health measures.
and in working collaboratively with public health, community health, and other community partners to develop solutions to problems that they see. There's some tremendous innovation, especially this year. I mean, we started from a modest place, and there's been progress every year. I have to call out Sinai this year. It's just amazing, your community benefits report. But these measures do cover all of the domains that you presented, Tom, including the sticky ones of social environments. You'll see child maltreatment is there. The collaborative of advocates around that topic who said, you can't talk about population health and not talk about child maltreatment, and said, well, you better help me come up with a measure that the secretary is going to approve, which is not an easy job, and they did. So we have that as one. We have suicides, those type measures. But it is a growing work in progress, and you can just Google DHMH SHIP, and you can see it all. They're all available by county, which does correspond for some hospitals to their areas of interest, as well as by state. And there are racial ethnic disparities presented for these if the numbers are sufficient to do so. So the big population measures have racial ethnic disparities. So it's a nice data source. It's, you know, just for having the big context. And some are very sensitive to what's going on in hospitals, like all those ED measures. We have huge numbers. You can see a lot there.
The only thing I would add to what Maddie said, because she did a ton of work pulling this up in a very short period of time, and now we are going through the process of refinement. Shuli asked me to present on SHIP at another work group, and we have a slide of the data sources, and they are much more varied than some of the ones you listed that we already collect as in due course, county by county through state surveys and other methods as well. So I think we have a good foundation. I think we need to refine what makes sense in a phased approach. I'm not sure that everything on the list we can change make improvements on in 3 years, but I certainly think we have a great foundation and a great place to start from.
Can I ask a question on SHIP? Is there any thinking about sort of a composite or roll-up, sort of a scoring that can sort of be trended over time by county, perhaps? Or
so this started very.
Yeah,
you can leave it on, actually.
It was crude the way we started this. I mean, we had a couple interns. It was. We did our best with very, very limited resources, no budget. But no, a couple of these include composites. So if you look at housing affordability, which is a new measure, that's a composite measure. Some of these are composites. But at the county level, you start to run into issues. They're just too different. You lose the meaning of those. However, if you look at a county profile, let's say we want to look at Baltimore County, and you go to their page, you'll see where they do worse than the average in the state, where they do better, where they're trending worse, where they're trending better. So you can see by measure, which we thought would be more appropriate for community action, unless it was the actual composite measure itself.
What I ask is, when I'm sort of thinking about the next agenda item, the balance scorecard, and if we're going to pick candidate measures for the parts of the three-part aim, it's like if we consider SHIP, do we piecemeal it or do we think of it in total? That's kind of why I asked the question. But we can have that conversation in the next. Yeah. Okay. And then I wanted to ask Dr. Nguyen about the payer perspective on population health, and from Blue Cross standpoint, what you may or may not want to contribute to the conversation. Sorry to put you on the spot.
Well, and that's simple. We're all for it. Makes perfect sense. So
yeah.
This is really a great conversation. So I was concerned about, hospitals can't do this. We can't impact these things, but what I'm hearing is not that. It's we want to impact these things. And maybe there's a way, like sort of the county measurements, so that maybe local hospitals can band together in some way. If they're in the same counties, maybe thinking forward, they could be responsible in some way for their counties. So it all makes sense.
And on that note of hospitals can do things that you might not realize, because I get to see these innovations in the community benefits reports. Where there's food deserts, some have started, farmers markets out of the hospital, or air quality issues, they're addressing that, or waste stream. There's a lot of creative things. Behavioral health, if there's no preventive care in the community, some have banned. In Carroll County, we see they've joined together to increase access to behavioral health care. So all kinds of things are possible. Hospitals have a lot of power.
We've also started out of the Health Systems and Infrastructure Administration working on the SIM, Community Integrated Medical Homework, looking at accountability, and Baylett, through a Robert Wood Johnson small pool of money, has started with Montgomery County. I'm just to your point of starting to ask people. We started with Holy Cross and are moving on to some of the other hospitals, community organizations, and provider organizations of what would accountability in a community look like, with many hospitals that may usually have more of a competitive nature. And there was a lot of conversation and talk about a hybrid model of utilization patterns, catchment areas, as well as county boundaries and geographic boundaries. So I think there's a lot of work to be done in that area, but certainly understanding who we're responsible for is going to be key when we start looking at population health.
Right. Another other thing I'd like to add is that we all know there's some communities that are more challenging than others and really need a lot more help. So if there's accountability and measurements, that all has to be accounted for.
Actually, I appreciate that comment. I was going to make a somewhat similar comment. First of all, just to respond to your really nice presentation, and this is wonderful. I think hospitals for a while have been really focused on their communities, maybe more than is known, but the variation is key. For instance, I think you said it well, Dan, certain communities, because of their composition, are far better in some of these indicators than others. And I think we're going to continue to chip away and try and seek grants and see how we can stretch our resources. Where I'm struggling just a little bit, and maybe that's the clarity we're going toward, is to figure out how that links to policy or indicators, because there's a big difference between requiring a roll-up that is the same for all versus, I'll take my own facility. I'm in the midst of a community, Sinai, that has substance abuse concerns, mental health concerns. So those are the areas we've really developed tremendously, and also pediatrics. Other communities may have different challenges. So I think this is all wonderful. We're all working at it, struggling, trying to find the resources, trying to work with the changes in the waiver to make that happen. But I'm not sure I understand the link here and how that will move into potential indicators or policy in a fair way.
So not to completely disappoint Dan, hearing that what hospitals can do. I think great points have been made about just how diverse communities are and resources, and clearly this is where we're all focused. I think one thing from MHA's perspective that we've been working closely with the department on is partnering and having kind of reinvigorating conversations with hospitals and local health departments and community partners, that whereas maybe 8 months ago it didn't make sense from a business perspective to partner, those conversations need to be revisited and to try to figure out how to leverage capabilities that are there, not try to duplicate where we don't need to, but at the same time recognizing that hospitals are the ones who are being held accountable. What I've always thought about SHIP as a former DHMHer is this is a great screenshot of our state, and this shouldn't be just on the shoulders of the Department of Health, and there should be partnership across departments where applicable when we're talking about housing, when we're talking about education and others. And I'd almost like to see the report that Maddie's talking about at a hospital level, at a statewide level. Like, where's that partnership happening? When we look at the areas that we are not quite on target, what's the plan there at the top level across departments? And then, maybe how are communities doing that as well? So just for consideration, I think we need to be partnering at multiple levels.
I think mine's more of a question than anything, and if Shulei's the least qualified in the room, I'm certainly a close second. But my question would be, this group I think formed out of the waiver and the reform and so forth. So at the end of the waiver, 3 years in, 4 years in, whenever we go to reapply to Medicare, what are we going to hold up to them and show them to say that we were successful in population health? Is it this scorecard of 40 metrics? Is it a statewide measure of 5? And I think maybe, Diane, that was what you were trying to get at a composite measure question. And I think that would also help us allocate resources. I mean, right now it feels like we're very pocketed. We're in our communities. We're doing what we can. We're focusing on what we think is important. But I don't know that we have an overall waiver, target, goal, statewide. This is the population health improvement that we're shooting for. Mm-hmm. So it's more of a question, I think.
Yeah, it's a good question. I'm afraid it would have been nice to have that sheet that we distributed in the last one. Out of these measures, I believe we picked around 10, if I'm not mistaken. And I would take that list and really carefully look at it, and we can do fine combing a little bit to pick the ones that we really want to target. Because the first one is the life expectancy, and I have a beef about that one in 3 years and all this stuff. So, I think we can take, so like there is a second list, a shorter version of this, and I think we need to come up with a little bit more narrower list, and then really maybe in the next meeting we can come up with looking at some data. The problem is we don't have any kind of targets, and I don't think there is any approach, a good approach to set feasible but aggressive targets on those measures. I think maybe in the next conversation we can hone on that list and then come up with, okay, here is the trend of those data, and here is, as a performance work group, we think should be prioritized, and trying to get a discussion about the targeting issue. I think the other kind of challenge to me is the accountability, and what do we do with hospitals who are sharing. If the one question is county a good, yes, all the data streams are based on county, but is the county a right boundary? So for some hospitals it works, for some it really doesn't. So how do we address that issue, one? The second issue is if they are sharing a lot, if 2 hospitals, 3 hospitals have a lot of overlap, what are the things that we can do to improve the collaboration? Someone in the payment work group mentioned we would have a free rider problem, that if one hospital, if you have 2 hospitals, let's say, they're going to look at each other to do the investment in the community, because at the end it's going to impact their global budget positively, but nobody would try to put the money up front, right? So I think that's the other kind of the challenge that we need to try to find a way to improve and to create the right incentive.
We're facing that real time with our JCHIP initiative and the CMMI grant, and funding for that stops. And then how, given now we have a global budget, and a lot of these services are outside the hospital walls because it's reaching out into the community, creating the networks in the community to help educate the patients. It's all falling back on the hospital to fund all of that. And ultimately, we may not get the savings from that, because if those patients were going elsewhere anyway, and now they're not going, then that savings is occurring, but it's occurring somewhere else. So it's a tough, especially, I think it's not as big of an issue with the Soul Community Hospital, who the majority of their business comes from kind of a defined area, but for inner city hospitals, and especially the academic medical centers, it's a big issue, because I mean, we've got 25% of our business comes from outside of the state. So, you know,
Right.
How do you deal with that?
I certainly agree with Ed's comment, but I also want to say that I don't think this is a simple question or a simple metric, and I hope we are agreeing that this takes considerable study. I don't think anyone disagrees that this is a very important direction, but I think the accountability question is complicated, and I think once you start trying to make that association with policy or requirements, it becomes even murkier. And I actually want to make a comment on Tom's presentation. You made a great point back on page 6. The population health measures, you were saying, I don't know if PQI essentially fits access, or does it fit compliance? What does it fit? Your confusion about that at your level is probably tenfold elsewhere because it is very confusing about the accountability question. And actually, I know in the end, we are probably tying a lot of this back to PQI PAU. Mm-hmm. And I see that we have statistics on that. I think we're going to have to be very clear here about what we study, how we hold hospitals accountable and others, and what is policy versus what is payment related. So I hope we're not going to make these decisions in a meeting or two. Mm-hmm.
Very good point. I was going to give an update on the PAU. I did a presentation yesterday on the payment work group, and then we start thinking about how we create the incentives for hospitals to start reducing the PAU volume under the global budgets. And I think there is going to be a sub-work group to really look in more detail, and I encourage you to participate in, because obviously those are very related questions. I do agree, especially PQIs is much broader than the hospitals. At the same time, we committed ourselves to move beyond the hospital, and I think Justin's, PQIs is a great example for me that this is looking outward from the hospital and trying to get some accountability for hospitals to say, okay, what is happening? Why am I getting so much PQIs in my hospital? And for sure, in terms of evaluation, I don't think it's fair to say you have 30% PQIs and you have 10%, and it's because you have different quality. I don't think nobody is going to be saying that. What we will be looking at is how much you can reduce that percent, and there is a big, analysis we need to do what is feasible given what your community is. And but at the same time, as HSCRC always kind of sets these incentives and try to direct the payment to a place where we want industry to focus on. And I think PAUs are kind of our immediate focus area, together with the high utilizer analysis that we are doing. I think the challenge is creating the community measure. It's right now it's the hospital and all the PAUs coming back to the hospital. Maybe we need to narrow it down to make sure that it's a place where hospital can have an action to.
Bottom, internet facts, one up right there. Facts, a couple more.
So there's a little bit of residual noise on the phone, and I wanted to ask if anyone had a comment on the phone.
Oh, great, yeah. That helped. I would have found it in there, but
Greg?
I would have had to
yeah.
hunt.
I'll
Yep.
show you what it looks like now. Yeah.
Okay.
Where is he? It's Greg, yeah.
Our
It's our IT person.
Our person who set up the webinar. Okay. So we'll check. Okay. Okay, great.
All right, Justin.
Yeah. So I just wanted to kind of, I think, piggyback off of what Barbara said, and I just phrased it, I think, a little bit different. I think with population health, certainly accountability is a concern, but I think the bigger concern, at least from my perspective, is collaboration. We jump into what the individual hospital can do kind of quickly because that's how we're all measured and that's how our revenue streams are. And but I think some of these population health measures are really going to be accomplished more successfully if you get the hospitals to join together and collaborate work together. And that's what you're hearing some folks say about the free riders. They're worried that they'll be the only ones collaborating in the group and they'll be carrying the load. So I think we just need to make sure that the accountability is really looked at from a collaboration standpoint, and then kind of the savings that are generated, if there are any, are spread equally, or the funding that's required is again spread. I don't want to say equally, that's not the right word, but fairly. Equitably is a better word. So I just want to change the dynamic, I think, a little bit of the conversation, because for me it's not as much about accountability as it is participation and collaboration. And that's why I asked in the original, which is if we have 3 or 4 measures, and I don't think it should be boiled down to 3 or 4 measures, but I think we have to know what we're trying to accomplish in order to figure out if we're getting to the goal. So if we have a really big goal that we're going to collaborate on, what is the goal, what are the measures, and how do we make sure that everyone's participating equitably?
I just want to make a very brief comment on that. I certainly agree with that in concept. Where it gets very difficult and murky is that we're not just looking at a city or a county, we're looking at the whole state. So Maryland is small, but we're so diverse that that collaboration, which I totally agree with, it just becomes also very challenging. But I do agree that that's what we need to do, and that's why I think this is a complicated process. I don't want to overly complicate it, so I don't know what that means, whether we start with some very simple, universal truths and goals and phase them, or whether we tackle the funding. I just think it's a very big question.
So maybe there's some way to give hospitals that participate significantly meaningful bonus points or something to reward that.
And the other, I think, could be, we've been talking with 46 hospitals and trying to create policies for 46 hospitals. It may make sense to, I'm trying to come up with grouping hospitals. So, the inner city hospitals, maybe we create a measurement just applicable for them in collaboration with them, and then find ways that they can collaborate themselves and find a way to reward them fairly for the results. I think, the market share is kind of, we've been talking about making adjustments to global budgets based on the shifts in the market share, which is kind of on its own track. But at the same time, thinking about the improvement and assignment of the population, from my analytical capacity, I'm really having a hard time dividing Baltimore City, for example, or Montgomery. So maybe we need to move to a discussion about, okay, let's forget about dividing it. Let's forget about giving you 30% of this zip code and the 40% of this zip code. But they say, okay, here are the zip codes you 3 hospitals have the majority of the revenue coming in. And here is their population health measures as we can collect, or here is the high risk. And then bring those people together and say, okay, what is reasonable and what can we do? I think, as we are saying, we are going to be patient-centric. I feel our policies are still at the state level, and there is a disconnect between what we expect hospitals to do at the patient-centric, but then holding them accountable to a uniform list that may not be applicable to them.
Yeah, and maybe I'm a little Pollyannish, I'm not sure, but it seems to me that we're trying to answer the question before we know what the question is. Yeah. And that's why I keep asking, like, the measures, that we pick as the most important ones. I think in my mind they should be the ones where Maryland stands out against the nation. Which ones aren't we performing well in? Which ones do we need to make the most progress? And I see a number in the document that, you could pull out: obesity, diabetes, influenza, addiction, mortality, infant mortality, cancer. I think they were all ones that were listed in your document. So my question would be, at the highest level, what are we trying to accomplish? Because then you can figure out where the pockets are in the state and figure out who needs to collaborate. And I don't even think the collaboration should be an HSCRC mandate or assignment. I think we could probably get there if we knew what we were trying to accomplish. MHA could really help facilitate the discussions. But again, for me at least, and again, I said I was the second least knowledgeable in the room, but I don't know what the goal is. I don't know what we're trying to accomplish right now. It's just very broad, and it's good discussion, but I think hopefully at some point we'll get to these are the measures that would really make a difference if we accomplish them.
Right, and yeah, I didn't mean I will bring people together or HCRC, but I need to find a measure to find a financial incentive or find a way to evaluate the collaboration. So I totally agree with you.
And don't forget, I think there's opportunities here in the work that is going on in your community benefits program. Because they've looked at all these measures, they've said, okay, we see we do worse in these areas, but we don't have the capacity. It's not aligned with our internal strengths or goals to address those, and they explain why. But we are going to address these. There's been a lot of work in teasing out what measures make sense, what are our, within our primary service areas, which areas we're going to focus on. Tremendous amount of work. So I think more of this has been thought through than everyone at the table might realize, at least by most hospitals. And we certainly want those things to line up. I think that they're helping each other out.
I was just going to add that I think the way that the impact policy was redesigned, it kind of is a model for us, and that it gives us kind of this is what the priority is, and if we make strides here as a state, we know we will be successful towards our waiver goals. And then now the hospitals are coming together and they're saying, okay, we're looking at these 20, we're figuring out where our opportunities are, figuring out who can teach, who can learn, how to collaborate, and it's kind of happening organically. So it's a good model, and so I think it's a really good point to say these 5 things, or whatever the number is, I think it needs to be small enough to focus, not saying that the good work that's happening at the community level won't continue to happen with community benefit and everything else, but this is really where we need to focus, and these are the areas where we need to focus, and then I think it'll come together.
So do you think that there is enough I'm thinking about the variation in the state, so especially in these measures. Do you think if you were to pick 5, let's say, do you think that will be broad enough that everyone has to improve, or how would you address the variation in the state?
So if you look across the local health improvement coalitions that vary among the state, which is really the local action that should be happening around these, when they picked their priorities, they had presumably partners at the table to collectively decide. And we have some areas that are very consistent across the state, but I do think that to your point, if you want to drive to a state improvement, we all have to be kind of rowing in the same direction, because if we do all pick separate things, we may not get there. So I think that with the idea of a subset and phasing to the point that then we can sort of align at the state level with what we're all doing and then drive those collaborations. And I think it's beyond just hospitals collaborating with hospitals, but to get there, we have to bring in folks that really do this as a full-time job and get them rowing in the same direction. So we're not splintering out. So I would just put a plug in for incentivizing collaboration across hospitals as well as within community, public health, and community-based organizations, much to the point that you made in your first slide about who needs to be involved.
And about the question of measures, if you look at the 19 health improvement coalitions, and hospitals co-chair all these, there's consistently 5 measures, for sure. They're all looking at diabetes measures, cardiac measures, obesity measures, behavioral health, and then to a certain extent you'll have one that does cancer, infant mortality, but they're more one-offs. You have those chronic disease dominate everyone's priorities. I think that's why those were lifted into your document from the SHIP measures.
So can I assign a task to one of you? For next meeting, if you could look at the measures that we list, and then with your knowledge about what each local community is picking as their priority, if you can reconcile those lists rather than me or Justin going through the list and picking the 5, I think.
Yeah, so we have that information. So we'll lift up the highest level priority areas, and then we'll crosswalk it, and where there's a difference or where there's similarities, and then there'll probably be a longer list, which we probably need to just shorten.
Yep.
Can I just ask a question? Obviously, I think we've said that we are all dedicated to this and it's important. Can you just help me with sequencing? Because I know we have data on PQI. I know we're, well, PAU, and I am having trouble understanding whether we will be focusing on PAU, PQI scores first, these measures first, back to Nicole's comment on MHACs, because there are connections with the MHACs to some of the community issues as well. I just need to understand the sequencing for policy and payment years, et cetera. So what are you thinking?
PQIs are, PAUs are the focus, I would say. That's our priorities. And this priority list is linked. I think they're affecting each other is one thing. But also, you know, the second discussion, the scorecard, if we have these as target, at least we put them in and start monitoring and thinking about it. And there is some local action going on and kind of support them that that's the direction we are going to go. But in terms of the policy or the payment adjustments, I think we are still focusing on more direct link measures to the total cost of care.
Is anyone on the phone? Is there anyone who would like to say anything? Any hands raised? No. Okay. So if we could, we can move on. And just let me check in with Denise. Did the recording go to the second?
Greg is he's going to come in and let me know when I can stop. He's waiting for it to end.
Okay. Just keep going. Okay. So this next agenda item was as a discussion of this notion of a balanced scorecard. And I think first we wanted to kind of define how we see what a balanced scorecard is and what its purpose is. So firstly, the characteristics are that it would present a mixture of financial and non-financial measures, and that there would be target values for each of these measures within a single snapshot report, if you will. That it's not meant to be a replacement for traditional finance and operational quality, et cetera, reports, but rather a succinct summary that captures the information most relevant for the target audience. And there, I don't have an explicit slide, but our target audience we see as ourselves, folks that develop policy, monitor policy, et cetera, and those who collaborate in that effort, as well as the target of that policy, which are here, the hospital industry. It also gives light to the organization's or project's vision and mission, so that, in my mind, we think would tie back to the three-part aim and what sort of build the measures down from there. As a model of performance, the scorecard articulates the links between leading and lagging inputs. These are human and physical processes, outcomes, and then focuses on managing these components to achieve what the organization has defined in a separate process of their strategic priorities. So I want to stop there and just ask if there's, if when we say balanced scorecard, is there anyone who thought it should be a tool for all, or patients should be able to use it? Maybe that's eventual. That's not what the scope of what we saw the balanced scorecard at this early stage. Okay. The next slide is the purpose of this, the discussion, is to come to an agreement on the concept and technical, more so framework for a preliminary monitoring and reporting system for hospitals and systems. And for us, as we, behind the scenes, under the hood, if you will, it needs to be easy to interpret with interfaces, graphically present to the business users current status, on these indicators, and it needs to include representations, trend charts, which allow users to rapidly make informed decisions, help users with situationally being aware, so that at a glance we could see if directionally, by looking at these set of however many, 10, 12, 15 indicators, is it going in the way that we want it to go or going in a direction that we don't want it to go. And then, therefore, some further investigation can be made to how to change the direction and in the positive way. And then also, it also helps make sense of a ton of data, which we know we at HSCRC do have. And you all said you had 19 data sources for SHIP alone. So, so what we're trying to do is make sense of a ton of information and data. So we did a preliminary product check that was not really for the scorecard, but it sort of is relevant as we think about the scorecard. The Audacious Inquiry did a market scan for us, and we tried to see if we were thinking about a dashboard that was probably more expansive than this in this earlier project. But really, we in this early market scan, they found that our rate setting system is unique, clearly, and that there's nothing that's exactly analogous in the regulatory environment. They looked at a bunch of different scorecards from other states. We need something different than the typical, and that the Kaiser Foundation State Health Facts seemed to be something that we could, that we were drawn to. I don't have a snapshot of that, but as a reference, at least as a starting point for something that we may want to look to, both for measure types and then sort of the user interface. So in designing this, we want a small number of financial and non-financial measures. We want to attach targets. This is repetitive, sorry. And we want the measures to include policy, business, organization leaders to focus their attention on specified areas. And although, again, it helps focus attention on strategic issues, the scorecard is not in itself a replacement for the formation of the strategy itself. So here we have this three-part aim that people probably have seen ad nauseum, but what we want to state here, what we've said in our model application is in these better care bucket, and what's in the better care bucket, what's in the better health bucket, and what's in the reduced cost bucket. So I'm not going to dwell here because I've broken each one of these out on the next couple of slides, and then put some example measures there. But all of the discussion we've had to the moment is very relevant to what we might consider as candidate measures in these buckets. So for better care, what we have now are QBR measures, and I think Barbara mentioned we've added these outcomes, CLABSI, mortality, PSI 90 in the outcome area. We have those process measures that are now lined up with the CMS value-based purchasing program, and we certainly have very high level of focus on patient experience as we weight patient experience in our scheme more highly than the value-based purchasing program. So those are the first set of improved care quality. But I think there are probably other measures. Oh, and then the hospital-acquired conditions that Nicole mentioned has gone through a complete redesign, and where there's been a prioritization and a more rational scoring methodology and incentive structure.
I wouldn't. That implies the old one wasn't irrational. It was irrational.
No, I said it's more rational. I am not afraid to be self-discriminating. I'm very sorry about that. See, And I'll apologize ahead of time.
No. I do think I also was laughing at the rational because I'm not sure that we can say that, but it does shake things up so that some hospitals who scored absolutely the best now don't, and some that were way low are now looking much better. So I think my comment is, I think for the data to be credible, it means that hospitals now have to slice it another way and look to see if there are quality issues that emerged by slicing and dicing the data differently. But in a number of cases, just from my talking with other hospitals, the change in the methodology does totally flip. And it causes boards and others to wonder and scratch their heads, okay, what is good quality? Was it good before, yesterday, and today it isn't? Or was it bad yesterday and today it is good because of the new methodology? So I do think we have to try to make that rational if it isn't. Okay?
Yeah, I mean, the stick before was more weighted heavily about the cost of excess PPCs. Now we are really looking at the numbers and the ratios. I think that changes what we defined as better quality before versus now. In terms of the list, I think, so this is kind of the available list. So if you're thinking about the scorecard, that will help us to monitor our progress and then, maybe early signs of improvement, or it seems to me we need to prioritize from this list and pick. So for the impact, for example, the question is, do we include the total PPC rate? So we are talking about statewide and then the same report for hospital, right? So do we have the total, all 65 PPCs as in our scorecard, or do we really want to have that 20 high priority PPCs in the scorecard to measure, just the 20? Or maybe you can have both of them to monitor. And then the questions to me in the, looking at the QBR measures, process measures, we've been reducing their significance, but at the same time, we recognize they are still important. Are they worth going all the way high to the?
I do believe, though, we have improvement goals in the model application for the QBR measures. So to that extent, how we might be monitored.
Well, so the scorecard is kind of the very high level. So and then we have this large monitoring list underlying it.
Right.
Okay. So I think when we consider the scorecard, we're talking about really defining the key indicators that are important from the global budget perspective and from the new models, thinking in terms of total cost. So I think, again, by next meeting, the question here is, these are the lists that we came up with. I think we would encourage, we would want you to think about what you think are the high priority lists that would deserve to be in this dashboard that we should be monitoring.
Right. So it's not that. So the balanced scorecard is not necessarily what's going to be submitted annually, for example, for monitoring. There'll be a compendium of measures that will be sent to CMS to show how we're doing on all the things that we.
Right. This is a tool for us.
As Dan mentioned, trying to make sense of all those things, I don't think it's feasible for us to look at all those measures. We want to identify these key measures that you think are important that we should be closely monitoring on a more frequent basis than the monitoring measure list that we have, which is much broader.
So I'm getting a better sense of what the audience is for the balanced scorecard. I mean, that was really my question. Often when you think of a dashboard, maybe it's for a hospital board, and it's that roll-up. Or maybe it's for consumers to support decision-making. Maybe it's for some other audience, policymakers, for accountability to CMS, or maybe it has aspects of all those things. But I think it would help us to think about exactly which measures if we knew the particular audience.
Can
you put your mic on, please?
The purpose of the dashboard will be for monitoring, primarily.
Yes, but also help industry and others to really see where they are lacking, that they need to do more progress. So it's kind of support the decision making at the high level. And in terms of audience, I think it's MHA, HCRC, hospitals. I wouldn't, consumers, I know they need something like that too, but I don't think that they are the primary audience for this purpose.
And I think the MHCC has a good venue for those consumer reports and the hospital guides, and so we shouldn't replicate or duplicate that work.
DHMH, would you be the audience for the scorecard?
I think as we have heard today, I mean, there needs to be a lot more statewide sort of integration and collaboration with driving towards these population health measures if we're going to make it. So I think we need to definitely be considered in that group. And I would also just put a plug in for like not having everything under the kitchen sink on here, but some very clear 65 to me is I'm rolling my eyes. No.
Not all the 65. I meant the aggregate total PPC rate of 65 versus 20. They're going to give you a different number. Yeah. or we can pick, sepsis or the top 5 that we really want to do more. I think there is this tension. You want to do it aggregate level. At the same time, you want to make it actionable, right? So if you have 65 PPCs there and you see improving, great, but we may be doing really bad on the sepsis, which we may think is a priority. I think that's the thing. We will struggle in the next meeting and come up with a list. Dr. Wynn, how about your perspective on the scorecard? What are the things that the payers would want to see?
Things that are actionable.
Are there things that, for instance, Blue Cross works on that are priority hot button areas?
It'll be the same as everybody else's priorities. I don't think you'll see a different list. I mean, it's what's clinically important, but I think it should be actionable. At the end of the day, what do we do about it?
Right. Keep in mind, we still have the monitoring underneath that you can always look into. But what we are doing is, since we have such a good group of people that are all together, kind of give the audience that high-level one, which we think are actionable, is I think a good term.
Some of the measures we're talking about, you're not going to see. I mean, I don't know the frequency of this, but you're clearly not going to need to look at monthly.
Right. No, it's a hard balance because those of us who are, well, everybody, but it's hard to take yourself out of what you know. It's fascinating. We're all interested in everything. We can't do everything.
Right. But I mean, if the measure is not going to be refreshed more than a year, probably not actionable.
It's not a dashboard.
Right. So we need to consider that aspect to it. Right.
So some of the things will be actionable in the short term that'll obviously, hopefully, move the needle on the things that we're looking at for population. But we need to be setting up actionable things to think about moving that.
So the other things under the Better Care bucket, as the model application was submitted and the contract executed, included improvement in care transitions, broadening engagement in innovative care models, and the notion was patients and providers involved in, for instance, ACO care provision, and then sustain high physician participation, and that was, I think, intended for the Medicaid program. So these were in the Better Care bucket, but to what extent do these other subdomains belong in our particular balanced scorecard is why there are question marks here. And I'm sure they have indirect effects, but I wanted to explore if there were ideas about how they might or people feel they maybe are not quite appropriate for this effort.
Were those two, those last two, were those the ones where the metric was to be defined?
Right.
The last one?
So there was the high physician participation is the % of physicians participating in Medicare and Medicaid. And HCRC didn't have that source, but Medicaid has some reports. So the idea is to pull those numbers from the Medicaid in our monitoring template. So these lists is our monitoring template. And the question marks are, do you think these are critical measures that would warrant the high scrutiny?
So state health facts help me here. They look at % uninsured, right? Mm-hmm. Is that a better, I'm just wondering if that's a better metric to look at coverage as our access proxy versus how many ACOs or PCMHs we have in the state.
Well, and maybe better health, well, better care. That's sort of an access issue. Mm-hmm. Yeah.
Yeah.
So state health facts.
I think that they use. I mean, I know that's one of the things. They have a ton of metrics on there, but
right. And so
to me, access is more: do you have coverage first versus how many ACOs are there in the state?
Right. So if we think about that one, we definitely, I'm sure the state has a target, and I'm sure we could report it statewide, and I think it absolutely could be broken out by county. And then the question remains at a hospital system or hospital level, how might one gather the data, or what would go into that measure to reporting that for a hospital or a system? So in Baltimore City, the hospitals all get the same number because they're covering, they're overlapping service areas, for instance.
Let me just make a comment. So having insurance doesn't mean you have access. Right. So, and especially with these new products in the exchange that have, $6,000, $5,000, $6,000, $7,000 deductibles that are combined deductibles with drugs and medical. So a person, needs to get a prescription. They haven't met their deductible. They have insurance, but they have to pay the whole thing. So just make sure that we're, I'm not sure measuring. I mean, who insurance is great, but it's not always.
But don't we think it would be I think it would be a noticeable absence if it wasn't on a scorecard that's supposed to look at the health of our state versus counting participation in innovative programs that hospitals really can't even participate in right now.
And I'm sort of thinking it through out loud. I mean, it has to be on there, but it doesn't. It's necessary, but it's not sufficient, as they say.
I agree with that. Yeah, I think these last two are a little squishy to me, I guess.
Right, that's why they got the question marks. So glad you guys agree with that. So we'll put sort of in the parking lot next to the.
I have a thought on that. Just as you're looking at the coverage of essential benefits, essential benefit providers across the state, there might be metrics here that relate to this access to an actual what you need, the kind of care you need in the location where you are. So there might be some, through the exchange, they might be collecting some information on that, I hope. And then the other thing, this is a comment from earlier. In work that, where we've had to have metrics nationally, stuff funded by CDC, sometimes they dealt with this issue like which measures are most important. So we definitely know actionable and important. But one way they've handled it is that there could be, core measures everyone's evaluated on. And then this option for Maryland, let's say, where we would have a list, based on we're such an underperformer in this area, or they would have very strict criteria that we could choose from. So if infant mortality is a huge issue in Maryland but not in Delaware, then you could pick infant mortality. So I don't know if there will be the possibility to have a standard set plus maybe some optionals that would allow hospitals to address areas that they really are concerned about that might be unique to a small group. Just a thought.
Yeah. And another criteria I think is we envision these scorecards to be at the hospital level too. So in terms of if we are doing not the big but the percent uninsured, then you need to worry about how you would calculate that measure for the hospital. So at this early stage, I think one of the screening tool for us is this something that we can measure for a hospital? And some of these measures, although they are important, probably are not going to be easily measured for the hospital. And we can create that list as, optional one, still hospital-centric, but then the other measures that are important, but we don't have an easy way of creating a hospital-specific one.
So we sort of brushed over improved care transitions, but we do have tangible measures, clearly readmissions, which is a huge area of focus, and then overall admissions, which sort of is a tandem measure with readmissions. And then the question is, what other things do people feel are important to measure care transitions?
Just to go back to the QBR.
Yeah.
So are we envisioning 3 separate, like one QBR score, or maybe just pulling out mortality, or what are your thoughts there? Or yes, you don't know.
Well, and I think Shule brought it up for QBR. There's these increasingly less important, regarded as less important process, but then there are these. I think people think are very important. The outcome areas, in our measurement, CLABSI, PSI 90, and mortality, and then patient experience is an area where we don't do well. So maybe we'd want to pick those 2 out of QBR and not the first one. The process, but why it's there is ideally you'd want to have leading and lagging, so you'd want to address the issue of process. However, I don't believe that anyone believes those 10 process measures in the VBP program have a strong link, because it's not been demonstrated in the literature, to the outcomes that are measured. So it's not a perfect measurement world, so maybe we wouldn't make that assumption, but knowing that we ideally would want these a balance of these different types of measures. That's why they're there.
I do think we have to always be careful if we present mortality by hospital or infant mortality by hospital, because there's a lot of confusion. Even if this isn't meant for a public, a consumer audience, you don't understand expected values, and it's just, I think we would need to be careful there, so someone doesn't think the hospital kills more people, and
Right, and
we just need to
right.
think about that.
I mean, we calculate rates. CMS does as expected, better or worse.
From the new incentives, that's a measure that I would want to put. You know what I mean? So I think we need to be careful picking the high priority where we are lagging behind the nation, and then think about the measures that we think we need to watch carefully given the changing incentives.
You asked for more measures on care transitions, because I think I don't know that we don't want to just look at readmissions and admissions, and I do know this is the big focus. But there's particular systems where we have transitions, and we know that there are systems issues that maybe even other state partners, bringing back that point of what people are doing as long-term care is changing. That I think there might want to be some attention to, because there can be, we just don't admit people. You could have some bad care transitions and not pick them up if it's just readmissions and admission rates. So I think there's going to need to be another measure that looks at how we're making the systems work together for people at a state level, state responsibility for that, as there's a lot of change going on right now in behavioral health, long-term care, disabilities. So putting in a plug there, too. I'm definitely the advocate at the table, aren't
I? That's good.
I guess, the other measures which are not easily calculated for now is the follow-up rates after a discharge within, I think it's 14 days is kind of the norm. I don't remember.
Yeah, and you know, it's HEDIS, and Dr. Wynn left the room.
And then the other one I'm thinking is the, again, we have data challenges, but admissions from nursing homes.
Yeah, I was thinking. So you're talking about making your major data challenges measured, or at least some data. So if you have like infections present on admission but admitted from a nursing home or something, are you talking about creating certain kinds of information for hospitals to use, and not just say you're going to be measured on it?
Right.
Yeah.
Right.
That might, because infection's a real issue too.
I think that's a great point.
That is a good one.
I think we need more information. I think hospitals need some of that information to make informed decisions about partners as well. So I think that's a great point.
And those data are available because actually I'm looking at those in my job now nationally. But most of these conditions come in on admission. And so if you know where they're coming in from, it can help you actually get at the root of the problem. So that would be much more interesting. Well, it would be a nice counter to what you have.
Nationally, what is available nationally? Can you explain a little bit?
So I'm sorry, this is just with Medicare. But Medicare, you can look at present on admission for infections, adverse drug events, whether they were present on admission or whether they occurred while admitted. And so that's illustrative of, you know, where you can make a systems improvement. At least that's our
Yeah, we can do the same thing. I was hoping you would say then you can link it and see whether they were coming from a nursing home or
They can.
they can, but
You get, yeah, they get that SNF specific stuff.
What is it in the SNF data quality data set?
Yeah.
Not OASIS, that's home care. What's it called?
No, it's in the hospital.
It's in hospitals.
Yeah, it's part A analysis.
Right. We've analyzed the admission source, and some of the problem is it's not reliable, which is an area we'd have to work on, because patients come to the ER from the nursing home, and then Paul Allen will tell you they coded as coming from the ER, not the nursing home. So there's not a high reliability about that. And in fact, we have Optum Insight auditing charts for appropriate coding, and we're looking at admission source and discharge disposition and the correctness of it to the extent the documentation supports what's coded. So we're trying to get at that from a auditing standpoint, but we do find some error rates.
That'll be an incentive for hospitals to improve on that as well, once they see that may be a way. Exactly.
Right. Right. Okay. If we do have 10 minutes. I know that we have a constraint on the ending of the meeting to be out of here within a few minutes after 11:30. So we'll not meaning to not pay attention, but again, this is the beginning of the discussion, not the end. The better health category includes reduce unnecessary admissions and ED visits, reduction in health disparities, increasing of sharing of health information of data through the health exchange, and then information exchange, I'm sorry, not the exchange, and then an improvement in health status. The first area, we have the PQIs, and we could look at them for admissions, but they're not really designed for ED, I don't think. So I think we would need to look at other options for unnecessary ED visits.
Yeah, the measures are good here.
Great.
I mean, you've got asthma, diabetes, hypertension, behavioral health, domestic violence for those who want to be progressive.
Right. Okay, so the SHIP measures are, the good news is they fit in a lot of categories. In terms of health disparities, our thinking was we've done a lot of work at looking at how well hospitals code race, ethnicity. We've added some requirements. You know, you have to be on par with the national standards. And then also we've added language, which is the language a person uses when they receive health care. And then we've also included country of birth. So we find that there's variation in the reliability of the data because some hospitals, for instance, have a lot of nulls or blanks in their ethnicity fields. So we've done a huge effort in the last year to inform hospitals of our expectations and what best practices are. We did several regional trainings throughout the state. And so I think we need to revisit analyzing what that data looks like again. And then before we would use it as an indicator of disparity, we want to make sure it's good. I think it measures well statewide disparity, county-level disparity in certain health indicators. But as far as at the hospital level and making discriminating judgments about whether there's a disparity of care in the hospital or there isn't, that's where I think there's limitations in the data from that regard. And as David Mann would say, let me say what he'll say, that we can absolutely get at black and white disparities right now.
And actually, I'd like to make a comment on that. I couldn't agree more that we need to put our toe back in the water and try to look at it again. I don't know if you remember, I think Shule, it was about a year ago, maybe more than a year, that we did have a demonstration set of data that was brought to the Maryland Hospital Association Council on Clinical Issues. And there was such, well, disparity in the disparity data. That if you know, for instance, I'll use myself, one type of cardiac patient, with one set of disparities looked fabulous, another not so good. So I do think it's going to take some work on that data. So if we get back into that again, that's a process that will take some time.
Right. And I think to start with, on this measure, we may not do a hospital-specific report, but follow it statewide.
Oh, that's really good idea.
And maybe, to be more modest, we can start with PPC rates by race and readmission rates by race, so that at least we are trying to get it and see what's happening.
And I think that, to your point, the point that I was going to make is we have to have something we're measuring to drive people to do better on collecting data rather than just measuring collection of data. So I appreciate that suggestion.
Good point, Raquel. So the next one's increased sharing data through the Health Information Exchange. And some thoughts there are, in addition to admission discharge transfer data, that's just that basic information. Are hospitals submitting, discharge summaries, clinical summaries, those sorts of things, content data as opposed to counting data. And I think more and more hospitals are doing that. And then also there's this encounter notification system where hospitals and providers can be notified. So to what extent are hospitals using the ENS?
And then a third measure, probably other providers. I think we need to start thinking about participation of physicians in the nursing homes. But again, it may not be a scorecard level, but I think we need to have that measure somewhere that we kind of are aware of our connectedness. We are great that hospitals did strive there, but yeah.
So the next one was health status improvement. And I think Shule added SHIP, thank you, yesterday. And the community benefits report is, I think Maddie talked extensively about that. And my understanding is that that is evaluated and scored, but there's some subjectivity to it in terms of the robustness of both the analysis of the needs and then the interventions that match those needs. And then the second point I think about that, now I know about 1 inch more than anybody else about than Shule and Justin, but nothing compared to Maddie. The other thing, Maddie, is how much hospitals expend, how much they spend. There's a dollar amount. But what is the right amount to spend is the question, so how you set a target on that. But that's a more objective number, but it's quantitative, but is it right? I don't know. That's, I believe community benefits.
Not overstating it.
Okay, great. Thank you.
It isn't a lot.
Okay, all right. So if we were to use community benefits, how would we frame the measure? Question. Maybe you could do a little thinking about that. And then we've already talked about SHIP, I think, at length, and we've got some good.
The only thing I would add there is the community health needs assessment, I think, is really the critical component that precedes the community benefit report. I think that you should have a comprehensive community health needs assessment that's well structured with community partners to then drive what your community benefit is and align. And hopefully, if we do this correctly, it will all sort of start to align with. And since they were required by the IRS this year, every hospital has that, so that is in place. The community health needs assessment, many of them are just amazing. You know, multiple data sources. So that is in place. There is a work group for the community benefits, an HSCRC work group that I think might be able to bring a balanced perspective on how some of that might be moved forward. Quite a few hospitals on that work group. So that might be an idea of a way to think that through.
I guess I would want to see that thought through a bit more. I don't know that I mean, even at the hospital association, when we report that, we give the aggregate number statewide, and then we do snapshots and highlight individual, like really innovative things that we think hospitals are doing. I don't know that it makes necessarily sense to say this is how much Mercy spent compared to Hopkins, compared to, you know, Charles Regional, because they're just they're different hospitals, different. I would just want to see that thought through a bit more if that's going to be on a statewide scorecard.
So next is the fun area, reducing costs. And so the reduction of overuse of diagnostics is explicitly stated there, but I think we should maybe be broader than that. And you know, we are updating the reasonableness of charges analysis so that we could have some hospital charge comparisons on relative cost. And are there other things that we could measure? I mean, there's these imaging measures that CMS uses, but do they raise to the level of a scorecard? I don't know. And then reduce per capita rate of cost, and we are working on developing per Medicare beneficiary per month cost trends, or per patient per month, I probably should say, or per person per month cost trends on various services and in total. And then utilization trends, and those are the old admissions, lengths of stay, those sorts of things. And then the potentially avoidable utilization. And maybe we can segue to the sheet. I know we don't have a ton of time. But the idea of here is to count the cost of this, not the things not the rates per se. The rates will inform the cost, but the costs are the important things here.
So I guess since we don't have much time, we are going to try to come up with the list of measures in each these more detailed, and we'll send it to you before the next meeting, so you have a chance to look at them and then add your measures and indicate the ones that we are going to try to make a broader list. So that we can collaboratively come up with a kind of the scorecard measure. And in terms of the payer savings, I just wanted to say, obviously Medicare savings is one of our targets, which is in the scorecard, should be. The other one is Medicaid savings. As some of you know, assessments are going to be linked with the Medicaid savings. We need to develop a methodology to do it, but I think that's the two savings that we would have in the scorecard. Because of their importance. All right.
For that card, is there a way to put like hospitals with like hospitals? Because I don't know whether it's just for me, it's harder to see this, you know, meaning like Kernan is such a specialty. I don't know if there's a way to group these, or if that would, if anyone else, no, okay. No problem.
The reason I say that is just there's an implication of ranking, and also we're a small state, so you've got tertiary and teaching and urban. I think well, we can look at that, but I think you sometimes run into more problems that way. It may be that you can look at tertiary teaching, but
about the raw peer groups.
Yeah.
What they,
there
was a big debate.
We have had a precedent of some peer grouping and then a
been,
concern about it, and
Yeah, right. It's just hard.
but maybe even if you put the location of the hospitals by county, that may help you a little bit, but not so much.
Yeah.
Size?
Size, teaching, tertiary, trauma. I mean, there are several types of groupings, but.
We'll work on it.
great. Thank you so much. That, as you know, the PQI sheets for illustrative purposes. So appreciate the keeping it to the meeting. And the next meeting's May 9th in the afternoon at 1. We will have someone who from Johns Hopkins, probably Jonathan Weiner, present on some things related to the health IT work and measurement link that he's doing there, and so.
And you said the efficiency report will be circulated via email for comments.
All right, great. Thank you.